the ear will always tell you what what it has to offer you by such things as pain, discharge, and change in hearing. And we had a wonderful case this morning. Without asking him about pain, discharge, and change in hearing, and then from that getting all his history, we would have been lost. We would have looked at his ear, we wouldn't have known anything. So we were able. So I always emphasize that. And once again, so before you pick up any instruments, look at the ear. You want to make sure you cover the history part of pain, discharge, and drain, either acute or chronic. That's all it can be. The other reason for this side, it's a question frequently asked. When you look at the ear day after week after month, you should use the same instrument, clean, the same light, same magnification. So the image you see over and over is impressed in your occipital cortex. You see that same image. Now, if someone handed me an otoscope to look at the ear, I couldn't tell you anything because I haven't used an otoscope for 50 years. That's why I use the operating microscope. I formed images with that. But you can do the same thing with an otoscope. You've got to use the same otoscope, same power, clean, same lens, same good battery, over and over and over again. So you see not only anatomy, but you see color. And you've seen that color before, the previous week, the previous month, previous 6 months. There was that slide I pointed out, of course, how poorly it was illustrated. No narrowness of the canal, and they didn't set the eardrum at a tilt, which is a mistake because they all tilt. Now here's a picture of an ear in someone who obviously, if we ask the questions, they may not have had any discharge or pain. They could have had a problem with hearing, but the ear has this appearance. But the color of the appearance is deceiving. You'll say, that looks gray to me. How could you have passed that as normal? Only because you captured the same image of a healthy ear taken with this type of film at the same speed over and over again. That's a normal ear. A lot of it is in terms of the quietness of the eardrum, and you can see the vascular strip, and the eardrum is nice and transparent. So likelihood of being something major as far as inflammation would be very remote, but you've captured the image of that particular color. Now, if you look at this ear, you'd say, oh, what do you see there? Well, you see a color change, and you see a color change just in the view of the tympanic membrane. You see a color here and color there. And so you capture that. Now you might say, well, what questions have you asked this patient? This individual would probably not have pain, certainly wouldn't have any discharge, but they would have a problem with hearing, because that's an effusion. This is a very typical picture of a middle ear effusion. Some people call it serous otitis media, secretory otitis media. I guess the code says properly is otitis media with diffusion, and that's what there is a effusion there, and so they have fullness in their ear, and their hearing is not very comfortable. It's not painful. It hasn't drained. The ear is drawn in. The eardrum is retracted. And that's why the malleus is so prominent. And there's a little dimple in this area called the pars flaccida, which has only 2 layers, skin and mucosa. Then you see this contrast between fluid and air, and that's a good example of an effusion. Now, they don't all look that way, but having captured what a normal color is of the ear, and you see that, you would know immediately, well, it's not the normal ears I've been seeing day in, day out for the last 2 years. I see a color change, and the patient tells me they don't hear well on that side. So you can immediately conclude that, yes, your picture tied with the history, indicates that there is an abnormality and there's fluid there. Now they don't have to all look like that. This isn't the best picture, but if you look real carefully in the top part of this eardrum, you see these little, almost like little air bubbles in through here. So that's another example of a middle ear effusion. Could be unilateral, it could be bilateral. So the complaint is, I just don't hear well. Now they may have had a prior respiratory disturbance to start this all off, but this ear is not acute. This is not an acute ear in terms of pain. It's just blocked or full or sort of muffled because there's fluid there. Another good example in this slide of not necessarily in relationship to the tympanic membrane or the middle ear space is the fact that you see all these ridges. That's a perfect example of how dead skin cells migrate out of the ear. And it just shows you that nice pattern. Those cells will eventually come to the external aperture of that ear canal. So they have fullness and not hearing well. Now here's one that's just completely filled with this so-called amber fluid. That's the one color that they've used for many, many years to describe effusions. They call it an amber, yellow, rosy, yellow, amber look. It just completely fills the ear. But the tip-off is there's retraction in the pars flaccida because there's negative pressure in the middle ear space. And the eardrum is pulled in. That's why we have this so-called chalky white eardrum. Now, in one of the previous slides, which I failed to point out, it had a perfect cone of light there. So you got to disregard the cone of light. Whoever started writing about that say that when you see a cone of light, the ear is normal, is wrong. You see a little cone of light here. That ear is not normal. What the tip-off is color. Color isn't what I normally see in a healthy ear. This middle ear has so much negative pressure that you'll get some blood from the mucosa, so it tends to take on almost a maroon look. Sometimes it's really real intense. It can almost look blue. That's why they'll describe it as a blue ear, because they have blood mixed with fluid. And again, the tip-off is the pars flaccida is retracted. And the eardrum is pulled inward, and of course the pars flaccida dimples inward. So the question is, what do you do with effusions? Well, it depends on which age group has the effusion, whether it's unilateral or bilateral, and real significant number of people who have effusions are children. You don't see adults with effusions. Oh, you will, sometimes after a nasty cold, but they usually can resolve disturbances in their middle ear space and with the activity of the eustachian tube, but children don't. So they have, particularly if they have it on both sides, their hearing is diminished. So the great debate is children with persistent effusions, and then maybe superimposed acute otitis media, it goes on for a long period of time, do they have a disturbance in their learning ability? Well, if you can't hear, you don't learn. There's a great debate. Some people say that has no influence, and others say that it does. I think it depends on the socioeconomic class that they're in. Whether or not prolonged periods of effusion with the 20 decibel hearing loss will take its toll as far as learning from year to year on that child as time goes by. And of course, the real question is if they have superimposed acute otitis media on effusions, then you kind of lean toward the consideration of the placement of tubes. And it's still a debatable point. It's probably realistically, well, it's the most common pediatric surgical procedure that's performed in the United States today, and probably overdone, in my opinion. A bit overdone. They've cut the criteria just a little bit, but it's done frequently. And you're going to see kids that have tubes. There's all sorts of tubes. A tube is simply nothing but an opening that allows air to get into the middle ear space to equalize air pressure. The effusion is caused because of negative pressure if you eliminate negative pressure with any kind of tube, you solve the problem. So some tubes are made out of metal, some are made out of silastic, some are made out of Teflon. They all seem to have somewhat of a little flange effect on each side. Is there one tube better than another? I don't think anyone can document that. For a number of years, they used a tube in the shape of a T. They felt those stayed in longer. I was never a fan of T tubes, but they were used for a number of years and I think still are. The ones that we use are simple ones that have little grommet on each side. But they come in all kinds of material, most of which is inert. There's even metal ones. And that's all that it does, is it eliminates negative pressure. Now here's an example of an ear with a tube in it. It happens to be a metal tube. Now that individual is probably not complaining of anything. If there had been a fusion, it's resolved, so their hearing's pretty well. It's dry, there's no pain. The best place to put a tube in is in what they call the anterior superior quadrant, because they stay in longer. They stay definitely. If you put it in the posterior superior quadrant, you may end up hitting the incus. You don't want to do that. So that's not an area. You don't want to put a tube in. This tube is sort of caught between the anterior and posterior inferior quadrants. The other thing about a tube, some tubes migrate through the eardrum. And that's not always the case. You might look at a child, they put a tube in, and here it is in the anterior superior quadrant. You might see that child again at 6 months and the tube is down here. It migrates through the tympanic membrane. Not in all cases. As it migrates, the eardrum heals itself. Usually when tubes get down into the posterior inferior quadrant, if they're migrating tubes, they'll eventually come out. Some will come out exactly where they're placed. The problem with a tube is if it's not open, it doesn't function as a tube. So here's a tube that's got a bunch of granulation tissue in it. Well, how did that happen? Well, they might have had a tube in place and had bouts of acute otitis media with otorrhea, inflammation of the mucosa of the midlar space, enough to plug the tube with granulation tissue. And this is as if there's not a tube there. See, the eardrum is drawn in, you have retraction here, and you see fluid there. There's a little patch of scar tissue called tympanosclerosis. But that plug eliminates the effectiveness of a tube.
So what's the otorrhea again?
This ear will eventually, this granulation tissue, let's see if we can show it, will build up to the point where there's a lot of granulation tissue, then it'll seep out. It won't be a profuse otorrhea, but it'll seep out and it'll have an odor to it. And you'll look in there and you'll say, oh my, what do I see? Or they'll say, the child had a tube put in 8 months ago, now I'm getting bloody drainage. And you wonder, what could that be? And lo and behold, it's granulation tissue blocking the tube or around the tube. So when you have bloody otorrhea post-tube placement, several months that have intervened, it's probably granulation tissue. You might say, well, if you have that and it's just in one side and the other tube is fine and the child's 6 years old, what to do? Well, there's no antibiotic that'll treat that. You can take a carload of antibiotics. It's not going to touch that granulation tissue. It has to be treated locally. You might say, what's the best thing to do? Well, the safest thing to do in terms of your care would be to make sure they start on ear drops and to use a lot of ear drops to see if you can essentially cause that granulation tissue to resolve. Now, of course, we can cheat a little bit because we have an operating microscope. We can look in there and then just literally, if some of the granulation tissue is accessible, pull it away and then just fill the ear up with, we use all these esoteric old anachronistic powders that work. And so we'll put an antibiotic antiseptic powder in there and just fill the ear up with any type of topical antibiotic. And you can do that yourself. You say, well, I'm not going to use expensive ear drops that cost $100 a bottle. I'll just fill the ear up with an ointment to come in contact with that. And it's surprising how beneficial it is in resolving granulation tissue. It's like if you put it on a wound. So you can do that, but you've got to resolve this granulation tissue. Otherwise, a tube is worthless. It's not functioning as a tube.
Does it come back after you treat it?
It can, particularly if they go through again a period of otorrhea through the tube, and their response to inflammation is such that they'd like to create this reparative tissue. Then that can come back again. Usually, when there's granulation tissue like that, that tube's been in there for a long period of time, and it usually has a bit of a tilt on it, and the tube may eventually come out as the granulation tissue resolves. Now, how long should tubes stay in? Well, if you ask 10 people, you get 10 different answers. Most tubes will come out on their own within 13, 14, 15 months. I never take tubes out. I've never taken a tube out. Either it comes out on its own, or I'll just wait for it. The only time I'll take a tube out is if it's been in longer than about 3 or 4 years. I'll remove it. By that time, the child's grown significantly taller, because there's a relationship between height and the evidence of recurrent effusions. You don't see 12-year-old kids that are approaching a good height that have effusion. That's another example of what height does to the effect anatomically of the eustachian tube. Now you see it in kids that have short horizontal eustachian tubes, but you don't see 11, 12, 13, 14-year-old kids that need tubes put in. Or if the tube is still there and they get to be that age, I'll remove it, because if it stays in for a number of years and you're forced to remove it, the likelihood of leaving a perforation is real. Now sometimes they'll come out on their own and the ear fails to heal itself. Well, if that's the case, and they're 2 or 3 and they're still quite young, 6, 7, 8 years old, and they have a little hole in their eardrum because the tube has come out, in a way, I wouldn't worry, because that little hole acts like a tube, meaning that it's venting that middle ear space. So just let these kids grow up. It may gradually seal itself over the next 2 or 3 years, and they'll be maybe 6 inches taller, and they'll have better eustachian tube activity. I personally do not repair holes in ears like this where the tube has come out and the perforation is still present. Nothing is more embarrassing than to do a tympanoplasty on someone who's 9 years old. You close the hole, a year later they have an effusion. Then you're going to put a tube through a graft. That's horrible. I've never done a tympanoplasty in anyone under the age of 12 or 13. Only then I would do it if they're nice and tall and they're growing rapidly. Because that's what will happen. If you close that and you haven't determined ahead of time whether the eustachian tube is going to work, particularly if there's a tube on the other ear and it's still in place, you can really be criticized. And when the time comes to do a tympanoplasty, you better be sure that the other ear doesn't have a tube in it and it's perfectly healthy. Because if it isn't, you've been putting tubes in that ear, you're going to end up having a perfect operation and putting a tube through graft. So a little hole. Now you might say, well, there's some that won't heal. Yes, there's some that won't, and they get to be teenagers and they have to be repaired. But it's not common. It's not common. Always remember the principle is that that little hole acts like a tube. And it's so small sometimes it has no effect on their hearing. Just like a tube itself has no effect on hearing.
Would you ever use like the cigarette paper or something like that? Is that something similar?
Well, you could. Cigarette paper works ideal in the fresh, broken eardrums from trauma. But you could do that. You certainly could. Whether it's going to be effective, I don't know. But there's certainly nothing wrong with doing that. None whatsoever. Usually with kids, they don't like when they're fussing with their ears. Wouldn't do anything. But mother says, well, can you cover with something to see if it improves the hearing? Well, yes, it's an easy thing to do. It may not stay on very long, but there's nothing wrong with that. Now, what do we have here? Well, once again, pain, discharge, and drop in hearing. These people are complaining of a significant amount of sudden pain, usually associated with a respiratory disturbance in terms of rhinitis or nasopharyngitis. This is a perfect example of acute otitis media with blistering. Nothing could be better in terms of seeing that. this whole vascular strip is engorged, and they've got a nice blister on their eardrum, and the pain is severe. It's usually a youngster. This is a very, 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 very common diagnosis. Acute otitis media, often bilateral, but the principle is pain, a lot of pain. They're not too concerned about their hearing, or they may not be old enough for them to understand the question. They just don't like this horrible pain that they have. Adults can have this as well, but certainly not as often as children. And the problem again is eustachian tube clearance is the cause of this. The bugs in acute otitis media are the same as they've been for the last 10 years. H. influenza, Moraxella, and strep pneumonia. They don't change. Sometimes there is so much fluid, it's almost like the eardrum is pushed out at you, and you can see that. This wonderful vascular strip is engorged with all kinds of inflammatory material in the blood vessels. The eardrum is pushed out at you. This would be called acute otitis media with an exudate in the middle space. And it's again painful. The eardrum is distended outward, often associated with other complaints, maybe the other ear, sore throat, or runny nose. Everyone in the family is sick. It's a very, very common diagnosis to make. The tip-off is pain and what you see in the ear. Sometimes it's so severe. Look at the nature of that vascular strip. That eardrum, when you see an ear like that, you pray that it ruptures on its own. So you'll get immediate relief of pain. All that eardrum you have to do is to suppurate, which means to drain on its own, and they'll get immediate relief. And that's why sometimes mother will say the pain was horrible until 3 in the morning, and then the ear drained, and I got all this serosanguinous material, and the child went back to bed. Well, that's okay. That's enough for today.
Oh.
Because you don't raise your hand.
I was like, oh, that was
Yeah.
fast.
So the last word is, if that eardrum were to perforate, would there be a permanent perforation? This is one of the times in medicine you can say never.
Wow.
It'll break through a hole that even under 16 power I can't see it, because it's usually in a fold, and it just takes a pinpoint hole to allow all that pressure to come out. Rarely does it leave a perforation, except for one condition. There is a subgroup of acute suppurative otitis media. Suppurating means that it drains. There's one subgroup in acute suppurative otitis media, meaning that it broke through, that will leave a hole, and that is called acute necrotic suppurative otitis media, and it occurs in people who are ill with some other illness as well, either bilateral pneumonia. They may have all sorts of other immunocompromised conditions, and they'll break through with a big hole, and they'll sometimes end up with a perforation. But that's not very common, but it can happen. It can happen.
So an ear that looks like that, though, that you hope would open up, probably will.
Yep.
How long do you give it? I mean, would you say, okay, that's probably going to open up in the next 24 hours, or if it doesn't, do you ever actually go in and drain them?
Well, it'd be ideal, but usually during children, they're not going to let you anywhere near their ear.
Mm-hmm.
I would cover them with appropriate pain medication with the hopes that it would break on its own,
Yeah.
or resolve with antibiotics. Years ago, they used to lance ears. That was a common practice for family practitioners that would go to home with little lancet knives and nick eardrums to allow pressure to come off.
Seems like the same
Yeah.
practice.